So welcome all coming on to the session 2 of the Intravascular Imaging Academy. In this, after having a brief discussion about how to interpret the image of OCT and about the basics of the OCT technique, I would like to discuss in session about how can we assess what the image is showing. So this would be a case-based session. So case one, 38-year-old male presented with interval MI and his angiogram showed 90% lesion in the proximal LAD. So this is an image. We can see in the long axis there is some tissue coming, or there is some plaque shown at just near this marker 30, between 30 to 40 in longitudinal V. And the cross section at the same place, we can see a structure with asterisks. So, even having a young age at 38 years, this patient is having few findings that are so we can see a signal rich, bright signals, homogeneous signal. So this is a fibrous tissue from 9 to 12 o'clock to 12 o'clock to 3 o'clock. But from 3 o'clock to 9 o'clock, we can say there is some uh, less signal rich, that is low signal rich, and it also has a high attenuation and the margins are not clear. So this most probably fits into the category of a lipid. It is a lipid plaque with this, so it is a fibrolipidic plaque, this patient, and this might have led to the ACS in this young patient. So coming on to the next case, that is 76-year-old male presented with infeval MI, and in LCX, we could see there was a 90% lesion, and the ballooning of this lesion was done. And after the ballooning, we took a run of this OCT, and because the OCT catheter was unable to go, so we have to predilate it. And we can see this, this shows the beautiful finding that the central is the catheter, then at 7 o'clock is the wire, it's after that, beyond that, it's the wire artifact. And at 3 o'clock, we can see there is an intimal tear. Although this is a fibrous, smooth structure is visible in the intimal, there's a lot of intimal fibrous thickening. But what happened after the balloon, it led to a intimal tear, intimal disruption, and this blood from the lumen is connecting to the media, and this is what is called as indissection, leading to an intramural hematoma, what we call as IMH. So it is very important to identify, because if we go with further aggressive ballooning, then this hematoma may extend. So at this moment, we should try to stent the vessel. In the same patient, in the distal part of the vessel, we could see on this 3 o'clock, there's a structure which is having this regular margins. So we could see, and with some ground glass appearance. So this is a localized calcific nodule that can be seen in the between 3 to 4 o'clock. And a bit distal to that, we could see almost a similar structure, but this is what is called as sheet calcium, because we can see that there's a longitudinal sheet like calcium which has a regular margins. So it's a well circumscribed, although and there is less signal attenuation as compared to the lipid, but here the margins are very clear. So it's almost a seed-like appearance that I often say, that seed-like appearance with good borders that is seen is a calcium. So we have to be careful, because many times sheet calcium and nodular calcium both can be problematic. Although nodular calcium is more notorious. Next case is 52-year-old male presented with non-STMI angiogram show 90% lesion in LAD. So we could see on the right side of the catheter at 3 o'clock, we could see there is a eco-bright structure. This is a signal-rich structure with very less attenuation. This attached to the this near it is near the lumen, extending to the intima. It is mainly a white thrombus, and there is some flap at 11 o'clock that might have precipitated this. And a bit distal to that, we could see there is a lacunar, the signal poor structure, which is circular. So it is mainly intimal vessels. So it's the plaque atheroma has galled this vasa vasorum. The vasa vasorum has usually present in normal up to adventitia, but these are the neo vessels. The micro vessels are formed inside the intima that is feeding this atheroma. So this is a problematic thing. This neo vessels are present. So that means this is helping the atheroma to progress. So this is how a vessel inside a vessel. This lacuna dark shadow structure that is circular can be seen in intima media, and this is a neovascularization of the atheroma. And this is how, again, it's a white thrombus, is eco bright with less of attenuation. So it is smooth bright structure, that is, it is white thrombus, and it can be differentiated from the red thrombus, because in red thrombus there would be high attenuation behind this margin. This margin would be bright, and behind this there would be a dark shadow. That means there is more of attenuation. And when the structure is bright and less attenuation, then it is mainly composed as a white thrombus. Again, at 5 or 6 o'clock, we can see there are new vessels that can be seen. So this is how we can identify the various structure on OCT. So case number 4, 36-year-old male presented with ventricular MI, angiogram showed LED pattern. So again, this is the eco bright structure. This is bright structure, and less of attenuation. Again, it's a white thrombus. And yeah, in the one-level plaque, we can see this puncta-like structures, and these are usually macrophages. Many times they have a back scattering. This radiating lines behind them. So we can see this puncta, bright yellowish puncta, and behind that we can the radiating lines. So these are the macrophages, and a linear structure, which is looks like a seed of a rice, and it is yellowish, bright yellowish structure, which is linear in configuration, is mainly cholesterol clusters. And in this particular patient, we can see also intimal flap that is seen. And this is how a plaque rupture looks like. There is an intimal breach. We could see the breach in the continuity of the intima, and behind this we could see a cavity, and probably this is the plaque that is ruptured, and the material inside theroma has evacuated from this place and might have led to a varicose triad. So again, this is the repetition of the prior slide, that is intimal tear leading to intimal hematoma. So case 4, 54-year-old male with unstable angina, angiogram showed circumflex 70% disease. So we can see a nodular type of calcium. It is well circumscribed structure with less this less attenuation, and it is a well circumscribed mixed signals as seen. And this is how thick calcium looks like. So we can see it's again from 3 to 9 o'clock, there is a sheet, thick calcium. And we also could see that this is a structure which is well delineated, well regular margins are seen. So this is how, if this would have been lipid, then there would have been no margin in the posterior spect, and there would be a huge signal attenuation, which is not seen in this case. So 75-year-old male present with antival MI, angiogram show 90% LED. So this is the mechanism of the ACS that was studied. So we can clearly see that we are seeing intimal breach. From this, there's a fibrotic lesion, signal bright shadows from this 2 o'clock to 8 o'clock to 9 o'clock. And at 11 o'clock, there is a breach in the intima, and we could see the plaque has ruptured. So mainly plaque rupture is the reason in this particular patient to develop ACS. So again, this is a different type of finding. This is how a myocardial bridge looks like. There is a central catheter. This is the less common. This patient presented, we could see the myocardial bridging on the angiogram, and we could see in adventitia, the linear adventitial muscular structure that is suggestive of the myocardial bridge. This is the diastolic phase, because in systolic there would be more compression. And in IVUS, we call it as a half moon sign. But here we could see on the adventitial side, there are various layers that are suggestive of myocardial breach. So again, a 55-year-old male presented with ventricular MI, angiogram showed 70% in the LAD. So this is how the OCT looks. So there is a on the right side we can see there is intima is smooth. On left side we could see there is an intimal disruption actually. So this is basically plaque erosion, and it is associated with the white thrombus mainly. Case number 8, 65-year-old male presented with ventricular MI, angiogram showed 70. So this is how many times the SCAD looks like a spontaneous coronary artery dissection. There is one lumen, there is flap, and behind this there is a false lumen. So we have to be very careful while we are taking the wire or OCT catheter across it, because many times it can extend the false lumen. So this is how spontaneous coronary artery dissections look like on OCT. Coming on to the case 9, 57-year-old male presented with unstable angina. After LAD, we could see a 90% eccentric lesion. So this is how the angiogram looks like. And we can see clearly that there is dark lipid shadow. There is a high attenuation behind this from 3 o'clock to 8 o'clock, and there is intimal thin intima, that is thin cap, which has ruptured. So this is a plaque rupture. And we could also see there is some white thrombus that is adhered to the intimal shadow. And coming on to the case 10, the 65-year-old female, known case of ACS, post-PHI2RC and RAD, now presented with this ACS. And we did this assessment of this lesion, and instant restenosis could be seen. So this is a stent struts we could see. In center we could see the catheter, and in between there is a bright signal rich structure that is homogeneous. So it is most probably neointimal hyperplasia, NIH, that is oftenly seen in case of bare metal stents. So coming on to the IVUS versus OCT, so OCT is more superior in giving us a better plaque characterization, better assessment of thrombus, better assessment of stent expansion opposition. But some are places where the IVUS would score more, especially for the ostial left mains, patient having the renal impairment where we can't give much of dye, imaging of the coronary artery, which are very larger, beyond 4.5 or 5 millimeter, or if the lesion is aortic ostial. And in calcium also, the IVUS is sometimes better in as compared to the OCT. So for this vulnerable plaque, I think OCT scores everyone else out because necrotic core, thin cap fibrous atheroma, thrombus, calcium, and most of the things are better seen with the OCT. So just in the this is the last slide I would like to show. This is a 39-year-old diabetic hypertensive female presented with ACS. So most probably angiogram was normal, but what this OCT revealed. So this patient fits into the category of Minoka myocardial infarction with normal coronary arteries because OCT is showing a plaque erosion with some white thrombus. So this is how many times OCT help us in identifying the real cause of the ACS. So this was all about the case-based interpretation of the OCT, and I will be coming up with the next session of this Intravascular Imaging Academy. So thank you all for patient listening, and this was all about this session. Thank you.